Thank all of you all who are watching these video series. We appreciate it, and we've had a lot of fun doing them. So we're going to start something a little bit different tonight. What's going on with the scapula in shoulder and arm function? Really, what does this bone do?
First and foremost, when we're talking about the scapula, you think of the body in terms of the kinetic chain and how it is the transfer point between the large muscles of the trunk.
Yeah, no, the way I like to think of this shoulder blade is it's the base of this long crane. The arm is a long lever arm, and its attachment to the body is through the shoulder blade. So if the shoulder blade is not working effectively, if you don't have a stable base there, anything distal to that can't work effectively.
I think you guys are exactly right. I think one thing from a biomechanical standpoint, when you look at a lot of the biomechanical studies, they're really showing humeral thoracic motion. They often don't capture the scapula, all the baseball studies, all the throwing studies, so it's sort of the missing.
Well, and I think another really important part about the scapula that's often underappreciated, certainly in our medical education coming up, was the importance of positioning the glenohumeral joint such that the arm can do what it needs to do. And I think that's just really something that's critically overlooked, that is going to be very foundational for tonight.
How do you think about the roles of the scapula in those two maybe separate populations?
So like looking at baseball players, overhead athletes, it's part of that kinetic chain. It needs to work in continuity with the lower body, the trunk, the arm rotation, and it needs to be in sync with those. Once they get out of sync, we start thinking about impingement.
And they are, and Dr. Grantham said it very well, is that the overlap exists where essentially you're still using the chain. You're just using it more in a confined space. Mm-hmm. And I think that's really where the distinction lies. Is that
anything else? Any other questions? Thoughts on this question here?
I think that's a fundamental concept to appreciate: proximal control for distal mobility.
How do these periscapular muscles function to optimize these scapular roles? So
portions of the muscle really are what control the scapula. And I think that's something that's very challenging, certainly for me to grasp and understand, but when you're approaching can be very intimidating. And so, if you think about just very simply like the scapular elevation, the shrug, you're involving the trapezius there.
Yeah, well, I think one of the problems in teaching anatomy is we teach it by sections and prime movers. We don't talk about a system. And it's a synergistic system that really has to work together.
Coordination of activation sequencing. And it's very funny. You talk about serratus anterior. Like you said, if you go prime mover, serratus anterior is this. But where does the serratus work for our throwers, for sure?
And the reality of it is we can't do that clinically. I mean, we cannot partition out and specifically say, I'm only going to look at X. It just doesn't work that way. The body's not designed that way. But I do think what it does is come back to, at least as far as updating your thinking, is going back to actually what's more of a foundational concept, which is architecture.
So how do you feel about that? How do you look at that, or how do you put that into your thought process?
Yeah, and that goes back to the kinetic chain, right? And so nothing can work distally if we're not strong proximally. And so that energy is a transfer from proximal to distal. And so with that hip stability, now I can activate those
around the periscapular area is the serratus, because I think the serratus by itself, if you don't have the serratus, then your scapula really doesn't work very well. I would like to ask your all's opinion about that.
Spent a lot of time working on the lower trap, but as I think what happens is we always worked on getting retraction first to get that stable base. And to 80, 90 degrees, you're good. You can function that way. But if you can't allow that to upwardly rotate, which is really where we find serratus anterior function.
Or some illustration of what we believe is normal. And so when we start to deviate from that, that's when we start getting into true dyskinesis. But to boil this down to even more specifics, it turns into landmarks and what we see and when we see them.
So we've covered the basics of the scapula, a bit of scapula function, dysfunction, scapular dyskinesis. So we want to thank you all for watching this. And we're going to have the second part now, which is going to be a little bit more clinical application. My colleagues and I have really had a good time putting these together. Hopefully you all will have enjoyed this part of the series. And if you want to see the entire video and others in the series, they will be available at www.kiblerscapulasessions.com. Thank you very much for your interest, and have a good day.